A 25-year-old male presents with localized knee pain and a low-grade fever. I'm showing you the anteroposterior and lateral radiographs of the knee. Describe the findings.
Okay, I see it. The radiographs demonstrate a well-demarcated geographic area of lucency in the proximal tibial metaphysis. This lucent lesion is surrounded by a thick, well-defined rim of reactive bone sclerosis. Crucially, there is no extension of the lesion through the growth plate into the epiphysis, and only a small amount of smooth, non-aggressive periosteal reaction is seen along the medial cortex. There is no evidence of cortical destruction or an associated soft tissue mass. Combined with the patient's low-grade fever, these findings are highly characteristic of a Brodie's abscess.
What is the differential diagnosis for a well-defined metaphyseal lucency in a young patient, and how can we differentiate them?
Well, the primary differential diagnosis includes a Brodie's abscess, osteosarcoma, a metaphyseal giant cell tumor, and an osteoid osteoma. We can differentiate a Brodie's abscess from osteosarcoma because the latter presents with highly aggressive features such as a wide zone of transition, permeative osteolysis, cortical breakthrough, and a spiculated periosteal reaction, or Codman's triangle. A giant cell tumor in children can occur in the metaphysis, but characteristically lacks a thick sclerotic rim. An osteoid osteoma presents with a smaller nidus under 1.5 centimeters and disproportionately intense surrounding sclerosis.
Explain the pathophysiology of a Brodie's abscess and the key clinical features of subacute osteomyelitis.
Okay. A Brodie's abscess represents a localized form of subacute or chronic pyogenic osteomyelitis, where the host's immune system successfully walls off the infection within the bone. The most common causative organism is Staphylococcus aureus, and the infection has a strong predilection for the metaphysis of long tubular bones, particularly the tibia. Clinically, it presents as a smoldering, indolent infection that can persist for several months, often presenting with localized bone pain that is worse at night, mild warmth, and pyrexia. Inflammatory markers such as the erythrocyte sedimentation rate and C-reactive protein may be only mildly elevated.
What are the pathognomonic radiological signs of a Brodie's abscess, particularly on magnetic resonance imaging?
On plain radiographs, a tortuous lucent channel extending from the abscess cavity toward the growth plate is considered pathognomonic. On magnetic resonance imaging, the penumbra sign is highly characteristic, appearing as a hyper-intense rim of granulation tissue lining the abscess cavity on T1 weighted images. On T2 weighted images, a double line effect may be observed, consisting of a high-signal inner ring of granulation tissue and a low-signal outer ring of reactive bone sclerosis. The abscess cavity itself displays high T2 signal and demonstrates thick, irregular rim enhancement following intravenous gadolinium administration.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these radiographs with prior examinations to assess for any rapid bone destruction. I would recommend obtaining a dedicated MRI of the knee to confirm the fluid-filled cavity, delineate the surrounding bone marrow edema, and rule out any joint involvement. I would communicate the diagnosis of subacute osteomyelitis to the referring clinician. Finally, I would suggest referral to orthopedic surgery for surgical drainage, curettage, and obtaining cultures to guide targeted intravenous antibiotic therapy.